Good morning, everybody, or good afternoon, depending on where you are. My name is Garrett Schmidt, and I am the managing editor for ACO Exhibit Hall. And I would like to welcome you all today to today's webinar by BetterNight called How Sleep Medicine Can Significantly Lower the Cost of an ACO's High-Risk Patients. A few items of note before we get started. All attendees have joined the webinar today in listen-only mode, so you don't have to worry about muting your mic. That's been done for you. Also, I'd like to let you all know that the webinar is being recorded so that you'll have the opportunity to rewatch the session later and or share it with colleagues or anyone you think would be interested. A link to the recording will be emailed to you by me following the presentation. And finally, during the webinar, you can submit questions at any time to our presenters using the attendee control panel, and we will answer as many of those as possible in the Q&A session at the end. These questions are also being recorded, so even if we're unable to get to yours during the allotted time today, we'll make sure to follow up and answer it via email afterwards. Okay, without further ado, our presenter today is Dr. Dominic Manafo, the Chief Medical Officer for BetterNight. Welcome, Dr. Manafo.
Thank you, Garrett. It really is a pleasure to be here and speak with all of you this morning. This is a topic that is near and dear to my heart. Just a word of introduction. My background is in pulmonary critical care and sleep medicine. And I've spent the last 25 years or so working to really try and improve access to cost-effective sleep medicine care. I've been very fortunate to work with an amazing clinical team. You can see Dr. Edward Saul on the top left. He's not only a physician, but also a dentist by way of Columbia. He's board certified in sleep medicine. And by collaborating with Dr. Saul, we've also been able to integrate dental sleep medicine into BetterNight's offerings. John Cronin on the top right serves as the medical director at Scripps Green Sleep Clinic in La Jolla, California. Again, boarded in sleep medicine and comes to us via Vanderbilt and Harvard University. Sam Clark is one of our medical directors, and he comes to us via Vanderbilt and University of California, San Diego, where he received his board certification in sleep medicine. And then last but not least, Dr. Derek Lowy, a clinical psychologist, co-founded the Insomnia Clinic at Stanford and has been instrumental in developing our insomnia program. Now, the CDC has really made it quite clear that we're dealing with an epidemic of sleep deprivation in our population. Some of it is self-imposed, so we don't get enough time in bed. If you go to bed at 12 and you wake up at 6, there's no way you're going to get the recommended 7 to 9 hours of sleep. But for tens of millions of Americans, they suffer from highly prevalent sleep disorders such as obstructive sleep apnea and insomnia. So here you can see that apnea is thought to affect as much as 18% of our population. That represents over 50 million Americans. The annual cost, the total cost, as well as the lost productivity is really quite substantial. Similarly, insomnia, chronic insomnia, affects probably 20% of the population. At any given time, another 15 to 25% of our population are experiencing symptoms of transient insomnia. Again, the total healthcare cost associated with that, as well as the lost productivity, is really staggering. Now, I wanted to focus a bit on some of sleep apnea's comorbidities. You can see some really striking numbers here. The prevalence of hypertension, obesity, depression, and coronary artery disease are all quite high in this population of sleep apneic patients. In addition, if you look at some of the high cost conditions such as drug-resistant hypertension, 83% of those individuals have obstructive sleep apnea. 71% of type 2 diabetics have obstructive apnea. Over 3/4 of congestive heart failure patients have some degree of apnea. A wide range, but a significant number of those that have stroke also have apnea. And about half of the folks that are battling atrial fibrillation also have obstructive sleep apnea. Now, I'd like to talk a little bit about the science that's behind some of these data. So let's begin with some of the metabolic consequences when we are, in fact, sleep deprived. So I would ask you a question. What would you say if I told you that I could take a group of otherwise healthy millennials, and within the span of about a few days, less than a week, I could convert their blood chemistries to that of a pre-diabetic? Well, that work was done at the University of Chicago, and here you see the results. Decreased glucose tolerance, decreased insulin secretion, increase in evening cortisol concentrations, and cortisol is the stress hormone. There's also increased sympathetic nervous system activity. That's the fight or flight response, leads to hypertension, tachycardia. All of these things are markers of prediabetes that would not be expected to be seen in millennials, but wouldn't be seen for generations or for decades later. Yet all of these things were present in these millennials. And what was the intervention? As you may have guessed, it was sleep deprivation to 4 hours per night for 5 nights in a row. So I think this is really eye-opening data. Now, if we continue along that metabolic theme, here you see some work that was done at the Mayo Clinic by Varen Summers. In this study, they sleep-deprived individuals to 2/3 of their normal time in bed. And you can see that subsequent to the sleep deprivation, those individuals that were sleep-deprived consume 559 additional calories. And these are calories in addition to their metabolic demands, in comparison to those who were not sleep deprived, who did not consume those extra calories. So it's not hard to see how someone with obstructive sleep apnea might be a setup for obesity as well as diabetes. Now, if we move from the metabolic, let's talk a little bit more about some of the cardiovascular consequences. Here you can see work that was recently published dealing with atrial fibrillation and obstructive apnea, looking at over 22,000 patients. And what they found was that obstructive apnea actually was an independent risk factor for stroke as well as systemic embolism. So again, a very important, a very prevalent condition, atrial fibrillation and apnea, producing an increased risk for the development of stroke. Now, what's interesting is there's a new form or a new type of sleep disorder that's being modeled with regard to cardiovascular risk, and that has to do with sleep patterns and whether or not they're regular or irregular. So here again, you can see some work that came out this year. On the top left, you see a regular sleeper. They go to sleep at roughly the same hour and they sleep for roughly the same duration. On the bottom, you can see an irregular sleeper where the bedtime is actually irregular and the duration of the sleep is also irregular. Now, if you look at the top right graph, you can see that as you move to a higher standard deviation with regard to your sleep duration, so in other words, the more variation there is in the sleep duration, the hazard ratio on the y-axis for cardiovascular disease increases. So that when the standard deviation was greater than 120 minutes, those were the most irregulars in terms of their sleep duration, the hazard ratio increased to 2-fold. Similarly, on the bottom, you can see that the hazard ratio increases as the standard deviation for sleep onset timing increases. So as the bedtime becomes more irregular, you can see that that was actually found to be a risk factor for the development of cardiovascular disease. So while we've known for some time that conditions such as obstructive apnea or insomnia might confer increased cardiovascular risk, we're now drilling down on some of the factors that may be involved, namely the variability in duration of the sleep as well as the variability with regard to onset of the sleep. Now, having talked about the importance of sleep and some of the serious consequences if you're not getting adequate sleep, you would hope that we would have a very efficient system that would help all of these patients come to medical attention and be efficiently treated? Well, unfortunately, the existing system really is quite broken. And here you can see the pathway that a patient often has to traverse. It involves a lot of silos of care. It's quite costly. It's fragmented. It can take a very long time to get through and result in thousands of dollars of expense. If we spend a moment to look at that, you see the primary care physician may or may not be well educated with regard to screening for sleep and the problems of sleep medicine. That primary care may refer to a sleep specialist. And the way the current system is often set up, that sleep specialist will then refer perhaps to an in-lab sleep study. After that sleep study, they might come back for another consultation where they would be referred perhaps for an in-lab titration and yet another consultation, all before they're being referred to a durable medical equipment provider for their therapy. And that durable medical equipment provider often is more interested in commodes and beds and walkers and doesn't have particular expertise with regard to sleep medicine. So you can see the arrows where there is fall off in this system. The net result of this, after decades of care, is that we have 85% of the folks with obstructive apnea still undiagnosed. About 50% of those who actually are diagnosed never make it to therapy. And then the sad thing is that even those that make it to therapy, only about a third, 33% or less, are actually adherent to therapy a year later. The average time to complete this can easily be weeks to several months, and the cost can be thousands, $3,000 up to $7,000, $8,000 in order to make your way through this system. Now, one of my big frustrations over the last 20 years has been, how is it that we can allow a condition that affects maybe 54 million Americans to allow that to go undiagnosed in 85% of those that have the condition? So once again, given the consequences that we see of sleep apnea, as well as the broken system that's in place, it's not hard to imagine, right, that the cost of untreated obstructive sleep apnea is quite substantial. Now, here's some data that was published this year by Emerson Wickwire. This is the largest analysis to date, looking at over 287,000 CMS patients. They looked at over 10,000 beneficiaries that had obstructive apnea and then over 276,000 control patients. And what they found was that the untreated obstructive apnea patients showed an increased healthcare utilization as well as costs across all of the points of service that they looked at. So you can see here in hospital visits, outpatient visits, emergency department visits, as well as prescriptions, all along the y-axis. And then this was looked at over the 12 months. You see on the x-axis, the 12 months prior to the diagnosis. The dark line shows our non-sleep disordered controls. Again, that was over 276,000. And then the orange line shows those with obstructive sleep apnea. You can see that the trend is up, particularly in the 3 to 4 months just prior to the diagnosis being made. Here you can look at the total mean monthly costs during the year prior to OSA diagnosis. And once again, we see the controls along the bottom and then the OSA cases during that last 3 to 4 months prior to their diagnosis, really skyrocketing with regard to total costs. Now, there are numerous other examples that support the Wickwire paper. Here you can see some other data around the fact that OSA patients have higher direct medical costs, sometimes for as long as 10 years prior to their diagnosis. That's from a Butterfield paper. And similarly, that the magnitude of difference in the costs can be directly related to the severity of the obstructive apnea. Butterfield also found that there were 32% more hospital admissions in untreated obstructive apnea patients than in those that were treated. And in the McKinsey-Harvard study, prior to diagnosis, the OSA patients utilized medical resources 23 to 50% more often than the control group. So what I've tried to the picture that I'm trying to paint is clearly there is a need for change in our current system. And I think there are a number of factors that have come to bear that make this time ripe for a significant change and a paradigm shift. We know that home sleep test studies, HSTs, are a far more efficient way to administer diagnostic testing than necessarily the old brick and mortar sleep labs. Auto-adjusting PAP therapy has also become widely used and adopted, and the CPAP devices are now smart. They communicate and they allow for us to perform remote management of thousands of patients efficiently. There's also, I think, become a critical mass of published research with regard to the impact of untreated OSA and the increase in healthcare costs that results. There's certainly a rising, I think, consumer awareness around untreated obstructive apnea. And at the end of the day, I think there's truly a recognition of the misalignment of interests. One of the quotes out of the Wickwire paper was that as the healthcare system shifts from volume to value, the economic aspects of the disease become increasingly important to patients, to payers, to policymakers, as well as to the public at large. So a system that has largely been focused on trying to generate as many consults and lab sleep studies as possible needs to be changed. So what is the solution? Well, I would suggest to you that this is a better way to approach it. So BetterNight represents an end-to-end, streamlined and accountable system that is fully integrated and provides for virtual care. So you can see on the left-hand side, all the way from a sleep health assessment to determine who's at risk for obstructive apnea, moving through to sleep education and a sleep report that documents that level of risk. And if there is increased risk, the availability of a telehealth consult within a matter of a few days. Similarly, when that consult suggests that that person does need a sleep study, that can be performed in the home. Those test results can then power a script for therapy such as CPAP, and then that patient can enter into a coaching support program that will help support them long-term, so that the dollars are now being spent on long-term support rather than on the diagnosis itself. So what's the consequence of implementing something like this? Well, what you can see on the bottom left is that what we've been able to demonstrate is that we can increase the conversion from a positive diagnostic study all the way to therapy by 50%. We've always maintained very high levels of patient satisfaction, and importantly, our adherence at 1 year at 67% is twice the national average. Now, an individual can go through this system from end to end in as little as 2 weeks with a cost under $1,500. So I don't think it's that hard to see how this can be a dramatic improvement in the very broken system that we currently are laboring under. Now, I want to speak a little bit more about the modularity of the BetterNight platform, because I think that's very important. We know that there are a number of different practice patterns in the community, and so it wouldn't make sense to only have one way in which an individual can enter into the system. So we wanted to be sure we could accommodate these many models. So you can see now fully on the left side, a patient can come in and perform their sleep assessment. That can determine whether or not they are in fact at risk for obstructive sleep apnea. That refers them then to an online telemedicine consult. However, if they've already had a sleep assessment and been found at risk, they can be referred in directly for the telemedicine consultation. Similarly, if they've already been seen by a physician in a health system, they can be referred for a diagnostic sleep study that can be performed in their home and then power the decision as to whether or not they need additional therapy. But if they've already had a diagnostic study performed in the existing pathway that they've been in, then they can enter through the therapy setup portion. And at that point, they can then be given a CPAP device. They can then be entered into the remote patient monitoring and ultimately their population reporting. And I'll speak more about the population reporting in a moment. You can see to the far right, an optional module also is the insomnia module, and that's what I referred to with regard to Dr. Derek Lowy and the development of an insomnia application. So here, an individual can enter the modular system wherever they need to based on their particular referral pattern. Now, I want to tell you a little bit about what is actually behind the BetterNight system. So we've been doing this for over 20 years, and the clinicians have been trained at some of the leading institutions in the country. We have over 180 highly trained professionals that are working to accomplish these things. We've treated over 30,000 patients annually. Again, as I mentioned, always with very high levels of patient satisfaction. On the top right, very important to keep in mind that our long-term adherence at 67% is twice that of the national average at a year. We try to publish our data and make sure that our data is reviewed by peers so that everyone can have confidence in it. And along those lines, here's a paper that we published recently in Sleep and Breathing. This really documented our telehealth capabilities as well as our industry-leading compliance. This paper was one of the top 2 or 3 papers that was most downloaded from Sleep and Breathing during that year. Now, the engine that ultimately drives all of the accountability is something that we call Clarity. It's our proprietary data analytics software. And what it allows for is unprecedented ability to produce outcomes as well as accountability. And I know, certainly speaking to this audience, accountability is a big factor. So it allows for objective reporting because we download the data in real time from tens of thousands of patients that allows us to exception manage those individuals. That means that we can reach out to the right person at the right time with the right intervention. And then we can also supply them as necessary, not in an excessive way, but in order to maintain and foster their level of adherence. So what does that actually look like? Well, here's an example of some of the population management reports that we produce. This is from an actual medical group that we work with. You can see the pie chart on the left shows the status of all their patients that were referred for a diagnostic study, whether they were complete or in process. On the right-hand side, we keep track of the diagnostic test results, whether or not we had an internal positive that we performed, or whether they came to us externally with a positive study or an internal negative, or didn't have a diagnostic when they reached us. So again, this leads to tremendous transparency in the population management reporting. Here, to move on now to the therapy portion, you can see the pie chart on the left shows the status of those people that were referred for PAP therapy, whether they were in intake, whether they're still in process, whether they're only getting supplies. Again, tremendous transparency. And on the right-hand side, we keep track of all our modem data and the status of everybody's particular modem. Now, here what you can see is the compilation of all those data. On the top left, the apnea severities give us a report of all the sleep studies that we've done, and we break them down by numbers as well as severity categories. On the top right, the modems give us information on average nights used, as well as average hours used, and then the average treated apnea-hypopnea index. So you can see for this group of 127 modems, there was over 83% of the nights the device was being used. The average hours used was 5.32, and the tested, or I should say the treated AHI was 3.12, well under the 5 that we're trying to achieve. And here for this group, their Medicare compliance was at 79%. Now, I'd like to provide you with a little bit of context about the savings that can be realized by instituting a BetterNight program. So here you can see this is some data that we obtained. This is claims data from a large employer, about 28,000 individuals that's self-insured. And we looked at their claims data and found that, amazingly, they only had diagnosed about 122 of their employees. And unfortunately, only 51%, 63 of them, had actually been successfully converted to therapy. What's staggering is that they spent over $500,000 in order to accomplish that. That translates into an average cost per patient to get them on therapy of over $8,500. And then the saddest thing of all is that when you looked at their data at 14 months, there was no evidence that anybody was still compliant with therapy. There was no resupply. There was no evidence that they were still using the device. So clearly, there's no direct cost reductions or additional cost savings opportunity. Now, when you put that into the BetterNight simulation, you take those same 122, and as I mentioned, we can increase their conversion to therapy by 50%. So instead of 63 patients making it to therapy, we can increase that to 92. Those 92, to get them on therapy, the total cost of care would only have been $173,000. And then the average cost per patient, only $1,785, as opposed to $8,600. Now, the most important statistic here is that at 14 months, we can produce levels of adherence to therapy that are in the high 60s and the low 70s. The direct cost reduction alone, you can see just between the 546 and the 173, is a $373,000 savings. And that doesn't take into account the importance and the benefit of having people well treated, which then reduces their comorbid complications. That can result in an additional cost savings opportunity of on the order of $230,000. So you can see that instituting a model like this can then result perhaps in a $600,000 savings all total. Now, what about if you instituted this in the setting of a health plan? Well, we've done that here in Southern California, and we looked at our experience with them. We've been doing this now with them for 22 years. We looked at their data prior to working with us and found that they were having on the order of 3.2 physician visits in order to get somebody on therapy. We've reduced that in the orange bar down to 1.2. They actually had more than 2 diagnostic studies in individual. So they were doing individual studies and titration studies and sometimes even a retitration study. We've reduced that down to 1 diagnostic study, which is an HST. If you look at their utilization of PSGs versus HSTs, you see they were at about 90% PSGs, and we've flipped that ratio. So now they're under 10% PSGs and over 90% using the HSTs. Now let's look at this same group and look at the conversion to therapy and the adherence to therapy. So again, on the left-hand side, you can see the conversion of therapy was, as we've seen throughout a lot of our book of business, about 50% conversion to therapy. We increased that to 75%. The adherence, once again, national averages through a large national DME, they were adherence was at about a third, 33%. We've doubled that to 67%. Now, what that means is that we were able to put 3 times as many patients on therapy, successful therapy, at 1 year. Now, I think it bears emphasizing that the ability to obtain 3 times the number of successfully treated patients at a year doesn't require any additional sleep studies. It just means that by increasing conversion to therapy and then doubling adherence, we can have a 3-fold improvement in terms of the benefit to the patients. So this affords the patient and the payer the opportunity to benefit from all the work and the cost that goes into diagnosing and initiating therapy. Now, the financial benefits of the health plan are substantial. You can see that direct cost savings per 10,000 lives looks to be about $640,000 annually, with the additional return on investment with regard to improved compliance and decreased medical care costs of $237,000. Leads to lower hospital admissions, high patient satisfaction, and then population management, accountability, and transparency through our Clarity system. Now, this example is really not that unique. So there are a number of examples in the literature with regard to the reduction in total medical expenses when OSA patients are treated. This is data from 2006, 7, and 8 Union Pacific campaign. And you can see that when they initiated the program in 5, the blue line was the PAP therapy, and the cost was a little bit higher when they initiated, but within 1 year, the blue line went underneath the orange line, and then the difference between the PAP therapy group and the no PAP therapy group only continued to widen. So that at 3 years, they were saving on the order of $2,400 per individual. Now, while this data is from a railroad, keep in mind that this is a condition that affects over 50 million Americans. So it's not simply a condition of truckers and railroaders. It is a prevalent condition throughout our population. Now, I know as ACOs, you're no doubt very interested in hospital readmission rates. And so there's data around that as well. This is from the University of Pennsylvania, Conrad Schwab, published in 14. And you can see on the y-axis the probability of someone not being readmitted to the hospital. And then along the x-axis are 30 days after discharge from the hospital. The blue line along the top shows that with full use of CPAP, the chance that they were going to not be readmitted was 100%. So none of those folks were being readmitted, whereas those individuals who were either partial users or non-users of CPAP showed significant readmission rates during the 30 days post-discharge. There have been numerous studies that have shown the benefit of treating obstructive sleep apnea. Again, untreated OSA patients costing $1,950 to $3,889 per year, more than those that were treated. And in that same study, inpatient costs 82% higher than the treated individuals. And then below that, 3 studies that showed a range of anywhere between $2,700 and $5,200 per year more for those cost savings for those that were treated. So what I've tried to do, I think, is review some of the science behind the need to treat obstructive sleep apnea, try to demonstrate that the current system truly is a broken care pathway, and that there is very much a better way to go forward. And then lastly, I wanted to show the dramatic cost savings that can be realized by identifying and treating this group of individuals. Now, I'd like to change gears for a minute and address the implications of the current COVID pandemic and how it affects sleep medicine. I know we're all obviously dramatically impacted by that. And so I just spend a few minutes discussing how that has impacted sleep medicine. So as you can understand, there are numerous concerns. One of them is the difficulty of adequately sanitizing sleep labs and all of the sleep lab equipment. Similarly, we need to be sure that we're sanitizing sleep equipment that's sent into the home. And while some providers have used classes where 10, 15, 20 people might be trained in on an HST at the same time, clearly that's not possible in the current environment. The other thing is that positive airway pressure usually requires an in-person interaction for it to be set up. Now, there is also some concern that PAP devices may result in aerosolization, and so someone with COVID that was using a PAP device needs to be even more concerned with regard to isolation and the possibility of increased contagion. If we look at some of the short-term consequences of these concerns, clearly there's been a dramatic decrease in the assessment of sleep disorders in general, certainly with regard to obstructive apnea, and the decrease in testing. There are a number of sleep clinics that are closed right now, at least temporarily, although, again, with the impact of this longer term, some of them may not reopen. There's been a lot of HIPAA non-compliant telemedicine performed over FaceTime and the like. There's been more reliance on home sleep testing, HSTs, and there's also a demand for disposable HSTs. There's also a demand for remote PAP setups. And one of the things that I think is very interesting as I look at some of these short-term consequences is that BetterNight has been developing these strategies actually for some number of years. So clearly we've been working on HSTs for some time. And even before COVID, we had built a protocol for using disposable HSTs, and we've accelerated that ability over the last couple of weeks. And so we rolled out disposable HSTs last week in order to meet this current situation. Similarly, remote PAP setups have been something that we've been working on for years, and we've demonstrated and will actually be publishing and presenting at the next sleep meeting, whenever that may be, our data that shows that we were able to perform remote PAP setups without the direct intervention of a respiratory therapist and still achieve the same level of ultimate compliance. Now, when you look at some of the emerging long-term trends that we see as a result of these concerns within sleep medicine, clearly we're going to have to rely on HIPAA-compliant telemedicine. There's also going to be, I think, a continued reduction in the dependence on brick and mortar sleep labs, and they will focus more and more on the most complex patients that do need to be directly observed. There's going to be an increase in the reliance on home testing, and as I mentioned, the use of disposable HSTs in the flu season, during the COVID season, is going to be an important longer-term trend. And again, remote CPAP setups will also be an important feature. I listened on last Friday to an ACO webinar, and it was very interesting to hear about the trend toward increasingly decentralized primary care medicine. This becomes particularly important when people are going to major medical centers in urban areas to receive their primary care. And as a result, when they're sick, the medical center then becomes a hotspot for transmission of highly contagious conditions. So the use of on-site and near-site primary care, the use of virtual primary care, and something that I learned about on Friday, on-demand text-based primary care, are all longer-term trends that will help to decentralize the primary care services in general, which will help us hopefully move from a focus on volume to value. Now, I think it's also important to keep in mind as we battle this pandemic that sleep plays a very important role in our health. So we've talked a lot about diet and we've talked a lot about cardiovascular, but there's a tremendous literature built up around the fact that sleep rejuvenates the immune system. As a result, it has the ability to reduce our susceptibility to viral infection. And the data have been published in which they instilled virus particles into the noses of individuals. They used two different populations. One was sleep deprived and one was not. And those that were sleep deprived had a threefold increase in the rate with which they developed symptoms. And then as we face the social isolation, the stress, all of the issues that the pandemic has brought upon us, sleep and good sleep has the ability to reduce the probability of developing depression and anxiety. I think all important points to keep in mind as we move forward. And now, if none of this information has moved you to see the significance of sleep, I provide you with this. Data shows that by addressing your untreated obstructive sleep apnea, you can reduce your golf handicap. So I think that's the true coup de grace. And with that, I will conclude my remarks, and I'm happy to take any questions that you may have. Thank you very much for your kind attention.
All right. Thank you, Dr. Manafo, and I was glad to hear about the golf tip there. So thank you for that. We do have a few questions that have come in, so I will ask them at this time, and you can answer them. I don't think we'll be able to get to all of these, but I'll ask as many as I can. The first is, in no particular order here, what work can be done with ACO claim data to pre-screen for apnea patients?
Yes, Garrett. So that's, we get that question a lot. And I think that one of the first things that you can do is that if you look at the data, you can see those that were already diagnosed with apnea in the past, right? So that's one way to look at the ACO population, find out who's been diagnosed, who's ordered supplies, um, and find out who's actually using the therapy. Are there continued claim data for those individuals to suggest that they're active with their therapy? The next thing to do really, I think, is to look at some of the common comorbid conditions. So again, just as we pointed out, looking at atrial fibrillation, those that have diagnostic codes for congestive failure, COPD, hypertension, diabetes, those would be the areas where it would be most important to try to find those individuals that would benefit from this kind of care.
Okay, great. Yeah, thank you. Next question is, our experience with PCPs is they hate to put the burden on the patient for compliance. How do you solve for that?
Yeah, that's another question that we deal with frequently. And I think that the important thing to keep in mind is that what I'm trying to convey is that this really doesn't put the burden on the patient themselves or on the primary care physician for that matter. We have the ability to unload that burden. So by putting all of the patients on devices that can communicate with the cloud and by downloading tens of thousands of data points every day on our patients, we know how they're doing without actually having to bother the patient. The patient doesn't have to do anything. And instead, we can then, through Clarity, devise exception management reports. And we can find all of those people who perhaps have an AHI that's over 5, or those individuals that are having more trouble with leak, or those individuals who aren't using their device at least 4 hours per night. We can set those flags, and then we can intervene with our coaches. And the coaches can then reach out to only those people that really need to be reached out to, and they know what to do when they speak to those individuals. So it really, I think that the burden on the patient is significantly reduced, and then the payers receive reports that have just unparalleled transparency and accountability.
Great. Next question is, what do you do to help ACOs get physician buy-in for this?
Yes, well, I hope that the last 30 or 40 minutes has done a lot to help ACOs and those that run them to see the value in what we do. In addition to that, we certainly are happy to educate the physicians and make sure that they understand the ins and outs of how this system works and how it's working for their particular patients to improve their chance of being converted to therapy, so that once that doctor writes a script, they can feel comfortable that their patient is actually going to be placed on therapy and that a year later they'll still be on therapy. I've traveled across the country before this social isolation, and I've actually spoken to a number of people where they've actually given up screening because they're so upset with the fact that even when they find those individuals at risk, they're being referred to a system that's so broken that they don't end up getting placed on therapy. And if they do get placed on therapy, all they end up with is a doorstop. So we try to reassure them that the effort is worthwhile to screen, to then get them on therapy. The other thing is that we can have boots on the ground, and we have local resources that can actually talk to physicians, to their care coordinators, and show them about how the program works. And I think the last thing is that oftentimes PCPs think that this will produce or result in a tremendous operational load in their offices, but it won't. We take that burden off of their care coordinators and off of the primary care physicians themselves.
Okay, great. Next question, in no particular order here. How do you fit a CPAP mask without face-to-face consult with a DME vendor?
Yes, and that's something that we've been working on, I would say, the better part of 5 or 6 years. And I think there are a couple of points here. One is that over the last several years, the manufacturers, predominantly people like Philips Respironics and ResMed, have been designing their masks in such a way that it requires less actual person-to-person adjusting. Back in the days when I was doing this in the 1980s, we would do a detailed examination of a patient's face, and we would look and we would determine, well, this mask probably is necessary. That really has gone by the wayside. And what we do is now, with our big data analysis, we know which masks work, and they work for a very high percentage of the population. So what we'll do is we have a fit kit that gets sent out, and it will have multiple sizes of a particular mask. And that allows the patient to choose the correct size and then to interact with a therapist, either with audio-visual or just audio, and talk them through any of the difficulties that they might have. And what we've found is that that is amazingly successful, and to the point where our long-term adherence in the remote CPAP setups parallels our experience in person.
Great. Next question is, are all supplies, equipment, and DME included in the cost scenario you mentioned? And how about ongoing replenishment?
Yes, that number included the diagnosis, the telemedicine consultation, and the initial CPAP setup with the blower, the CPAP generator, the mask, tubing, filters. All of that was included in that initial pricing. So again, at a fraction of the cost of what has been done traditionally. As far as ongoing, then the individual will be monitored and coached, and they will be resupplied on an as-needed basis. And the interesting thing we found on the resupply is that, as an example, Medicare allows for someone to have a new mask 4 times a year, every 3 months. Well, we're actually achieving these results with on the order of 2.2 to 2.4 masks per year. So we do this at less than Medicare reimbursement or Medicare resupply rates, and still achieve compliance that's twice the national average.
Great. Moving right along here. Next question is, it sounds like the BetterNight modules are all reimbursed. Are there any restraints on telehealth reimbursement?
Well, there have been. They typically center around whether or not consults are done synchronously or asynchronously. Clearly, over the last few weeks, the restrictions on telehealth have been rethought and have been relaxed dramatically. And as a result, obviously, there are a lot of HIPAA non-compliant forms of telemedicine that are being performed. What we do is we're licensed in all 50 states. And so we look at each particular state and abide by whatever the state requires with regard to telehealth. Most will allow some degree of asynchrony in the telehealth consultation. So that means that a patient can submit a questionnaire that we provide them with, and then a physician can look at that asynchronously and then make a referral for an HST. So the answer is that there are regulations. They go state by state. We're licensed in all 50 states, and we abide by whatever restrictions might be in place in that particular market.
Great. 2 more quick questions, and then we'll wrap it up. First is, what is the format for which clinical info is moving between EMR and PCP?
Yes, so that can vary. We're flexible. We have a gentleman named David Guthrie, who is our chief technology officer, and he came to us via WebMD. So he's got a very deep experience in being able to handle integration with various EMRs. We work with Epic. We have our own EMR, and we can work through the technology teams to try to achieve the best integration that we can. So we're very sensitive to that need, and we understand that data is only valuable if you can actually access it. And so that's why we have so much emphasis on being able to acquire data, and we have people like David Guthrie who can help us to make that data accessible to those who need it.
Great. And last question here, and we'll wrap up, is what type of payment model are we talking about, cap or fee for service?
Yeah, so right now this is a fee for service model. I think that particularly in addressing this audience, we're certainly willing to talk about how we can take some risk side by side in the market. We understand what ACOs are trying to accomplish. It's been our mission for over 20 years to try to provide cost-effective, high quality care. So we understand that mission very well, and we'd be happy to discuss, various reimbursement models offline with any individual that had particular questions.
Okay, great. Well, that's all the time we have for questions, and we're going to go ahead and wrap up. Thank you so much, Dr. Manafo. And again, for those questions that we were not able to get to today because of time constraints, we will answer them via email. And so if you want to even include one here as we're wrapping up, that's fine. We can get back to you. As we conclude, I would like to encourage all of you to visit the BetterNight exhibit booth at acoexhibithall.com, which you can see right here on the page, a little snapshot of what that looks like. And you can go there to learn more about them and connect with their team. And this is also, ACO Exhibit Hall is also where the recording of today's session and the slides will be available for download, and you'll find those in our reference library. But again, I will send out a link to you via email after the presentation with a link to the recording. Lastly, if you have any specific questions for Dr. Manafo or the BetterNight team, feel free to reach out to them. Their contact information is here on the slide, and they would be happy to follow up with you for further discussion. And with that, we are concluding. So thank you all so much for attending. I know this is a crazy time, and so appreciate you making time in your schedule for this. And I hope you found it helpful and informative. So thank you again, and have a great rest of your day.